tonight, as I had started last year, I invited an additional face to come join me to give you a broader exposure to what we're doing at MGH in terms of tackling brain cancer. And so tonight we have Dr. Jörg Dietrich with us. And so I will just start out and give you a framework for what we're dealing with, and then to update you a little bit about the Miles for Mary project that you all have been part of over the years. So, unfortunately, glioblastoma is the most common and most aggressive type of primary brain tumor. In the landscape of cancers, it's a pretty rare cancer with only about 12,000 cases each year in the United States. So there's not as much knowledge about it compared to cancers like breast cancer or lung cancer. We try to treat these tumors very aggressively with a combination of surgery, radiation, and chemotherapy. Unfortunately, though, despite this very aggressive therapy, the median overall survival is only 16 months. We have learned in the last few years that there is a lot of variability in glioblastomas, and so the particular makeup of somebody's glioblastoma certainly influences an individual patient's prognosis. The challenge with immunotherapy in primary brain tumors is that we're dealing with a tumor that's inside the fixed skull. And so for those of you who were here last year and saw Will Curry's talk, this was a slide that he showed that exemplified this problem that we face with glioblastoma. So what you see on the top row are MRI scans, and the patient has received the contrast agent that lights up the tumor. Was treated with immunotherapy, and you see at week 5 that there is this big, robust increase in the uptake of the contrast dye. The challenge is it's hard to know at that week 5 time point whether or not that increase in contrast enhancement is actually active tumor or it's the inflammatory response that we want to see in the setting of immunotherapy. Lucky for this patient, they continued on therapy, and you can see that decrease in contrast enhancement. But it's very challenging to know at week 5 if you can just sit and wait, or if you need to do something different and treat the patient with a different kind of therapy. So what we've been doing with support through the Miles for Mary support is that we've been doing a clinical trial using a novel PET tracer to try to tease out if a patient who's treated with immunotherapy, when they have that MRI scan that looks very concerning for active tumor, is that really active tumor, or is that the beneficial immune therapy response that we want? One more. And so we're doing a special PET scan, which is called a PBR PET scan, that's supposed to be a marker of inflammation. And we do it prior to starting immunotherapy, and then after they've had about 2 months of immunotherapy, to see if there's any change in the uptake of the PET tracer that's supposed to mark inflammation. And then, based on our PET scan, eventually the idea would be you decide whether or not they have active tumor or they have inflammation. If they have active tumor, then obviously you need to change therapy. If they have signs of inflammation, you can keep them on treatment and persist with your immunotherapy. The other challenge that we face, even just with patients who are getting standard chemoradiation, which is the way, as I said, we treat these patients, even after they go through chemoradiation, you can sometimes see this inflammatory response, which again is hard to distinguish from active tumor. So we have another arm of our clinical trial where patients get this PBR PET scan at that time when they're most at risk for having inflammatory-related changes, and we're trying to help sort out if that's really active tumor or if it's inflammation. And that spares patients the challenge of having to go back for surgery, which can be invasive. And a lot of patients don't want to keep going back to surgery to look at what's going on under the microscope to figure out if these changes on the MRI scan are active tumor or if they're just an inflammatory beneficial response to treatment. So where are we at this point? So this is a pilot study because this is the first time we've really used this PET tracer in patients with brain tumors. So we have 6 patients enrolled overall. Our goal was 10 patients total. And so we're still in the process of analyzing this data, and we're hoping to have these 6 patients and hopefully a couple more enrolled, and have this the results submitted to our National Oncology meeting in the winter time. So I'll show you one picture from one of the patients who's gone through this series of PET scans. So we do both a PET scan and an MRI scan simultaneously at the same time. And so on the top row, you can see prior to treatment, that bright white spot is the area of active tumor. The middle panel shows the blood flow to the tumor, and then the far right panel shows the inflammation in the tumor. And it's a little hard to see, but this is a little bit of area of inflammation here. And then after the patient had gone through 1 month of treatment, you see this change in the tumor here, where you have a decrease in the uptake of the dye. And then here you have a decrease in the blood flow to the tumor. And you actually see a suggestion that there might be a little bit more inflammation in this tumor. So these are some of the changes that we're seeing. It's a new tracer. We really need to figure out how it's actually, how best to interpret these results. But there's some suggestion that there might be some signal there. So what's our next step based on the work we've done so far? So I applied to get funding to do a novel immunotherapy trial, and we got funding to do a phase 2 clinical trial of this new drug called bavdegalutamide. What's interesting about bavdegalutamide is it is both an immunotherapy as well as it targets a particular molecule on tumor cells. And so glioblastoma cells express this molecule. So you're both targeting the tumor as well as releasing the checkpoint on the immune system. And so we were going to start conducting this study in newly diagnosed glioblastoma patients. What we need to sort out is whether or not we incorporate these PBR PET scans that I've been talking to you about for the last couple of years, and that'll really be based on our further analysis of the data as it matures. So this is our next step. This is the group that I work with, my research group, and that's all I have. So that's the update on the Miles for Mary project, and I will turn it over to Jörg.
Well, so first of all, I want to thank you all to be here, because it is very critical for our work. Talking about a topic that we don't like to talk about much, because it is not always good news in a sense, but I will give you good news throughout that talk. And I thought I'd do it a little bit different tonight, because I thought I would use it also as an educational session, so everybody who leaves here tonight should have learned something new and take it home as a take-home message. And I think that hopefully will be a good educational session as well. All right, so we'll talk about something that is dear to my work for the past 20 years, which is that any treatment for cancer has collateral damage. And the collateral damage is sometimes affecting our quality of life. You might come home while you're getting the treatment and you're more fatigued, or you might complain that you just don't remember things so well. Used to multitask, do everything at the same time, and yet now you have to do one thing after another, and it's just not working as well, your brain. And maybe you are not even the one who points it out, but your spouses or your children are. And that's something we have been looking at for years now to try to understand what is the basis of this. So this first slide gives you what you find in the press. You have a friend, you have someone in the neighborhood who says, gee, I've been treated for cancer and I don't know what's going on, but I just feel like fogged up. Something is not right anymore, and I can't concentrate as well. I don't have that attention that I used to have. And my family members tell me I just forget things. And so you heard that term chemo brain. And chemo brain is something that I usually don't use as a term because it's not as scientific, but I help to dissect this as much as I can now in the next 15 minutes so that you have a better understanding what is behind this term and how we have in the past 15 years tried to tackle this issue with the goal to make quality of life and survivorship better in patients who have been treated for this disease of brain cancer or have survived this disease. If you look at the literature, and the literature is actually driven by patients who have been treated for breast cancer, because women are maybe more outspoken. Men don't like to talk about their problems, and they're more shy and say everything is okay. But because of the breast cancer field, this has actually been creating a whole new field of investigation in oncology. We do know that attention suffers in survivors who have been successfully treated for breast cancer. Concentration is an issue, processing speed, you just read it with me, executive function, but also learning, working memory, and visuospatial function. What is that? It means I cannot really figure out a good way how to get from place A to place B. That's visuospatial navigational skills. And when I came into this field about 15 years ago, we came to the understanding that it's not just all about brain cancer and its toll on the brain. It's almost any type of cancer that has been treated with either systemic chemotherapy or, even worse, with radiation to the brain. And so I'll give you a little bit of a summary now of what, as a physician, as a clinician, we see in clinic, what are complaints we deal with, and also how we've learned in my group and in others to understand the fundamental basis of memory disruption and other side effects of chemotherapy on the brain. And I think that's the most important message, what you can do about it to make this much less of a burden. So you might scientifically ask, well, wait a minute, there's not only just treatment for the tumor, there are many other things. There's maybe genetic factors, because my neighbor got exactly the same treatment and he says, I'm fine, I'm playing golf, I have no handicap, and the other one says, well, I'm done. I really am at home, I'm withdrawn, I don't want to meet people anymore, I don't want to talk. So what are the differences in patients? Is it just about the chemotherapy, or is it maybe something else? Is there a mood disorder that might play a role? Is it issues of fatigue? Is it stressors of other kinds? And so one of the big issues is in this nebulous field of complexity to tease out these individual factors. So on the next slide you see something we do not like to see, which is everything that's white is not normal. The brain, this is an MRI again, of an individual who was treated with a drug called methotrexate for lymphoma. Another patient has been treated with a drug of methotrexate and cytosine arabinoside, or ARA-C. And yet another patient just received this ARA-C compound for different diseases. AML is a leukemia form, CML is a leukemia form, the other one is a lymphoma. And the brains look fairly similar because they all have something white that is not normal. And this is toxicity. This is toxicity that Dr. Gerstner will pick up when she does her imaging studies. And said this is something that is not belonging there. And we in our team try to figure out why this is and how we can prevent this damage. So the next slide, we'll talk a little bit about myelin. I'm not sure if anyone has heard about myelin and what this is. Myelin is the basic insulation material around a nerve fiber. It's a rich protein layer. It's like a cable. If you have a cable here and strip it off, the myelin, which is the insulation material, it's not a good idea. It's going to cause a short circuit. And that's exactly what you see in patients. They have short circuits, so things don't work as right. And we are trying to figure out why the myelin is not behaving well, or why the myelin is so vulnerable to things like radiation or chemotherapy. So this is a patient who has been successfully treated for a tumor called glioblastoma. She was diagnosed in 2003. In 2013, the brain looks pretty much beat up. Beat up in a sense of that you see more white areas, you see more dark areas on this GRE. And as a physician, we get a little bit worried about this because you always suspect maybe it's tumor that's driving all these changes over time. The truth is that this particular patient, I'm not sure if Dr. Martuzza is still here, got treated with explorative surgery 3 times to figure out what the underlying problem is, and it's all treatment-related effects. No evidence of tumor whatsoever, but a lot of necrosis. Necrosis means tissue damage. And so we knew that what we've seen on the scan was not in essence a bad thing because the tumor was not evident. However, there were a lot of changes that caused this patient to have a lot of trouble. And so you could say, well, what's the price of this harsh treatment on the brain? And how could we have prevented this? Should we have done less radiation, less chemotherapy? And so these are the questions that go to the heart of this topic. Next slide. And this is just one other example that gives you a little bit of a flair of things that might change over time. This is a young individual who was in his 20s when he was treated with a tumor called medulloblastoma. It's a tumor that affects a lot of kids. Got radiation and chemotherapy, and then over time you see something interesting is that the brain volume shrinks. You see these areas that open up over time, and then you see black dots appearing. Black dots are signs of vascular toxicity, and fortunately this patient didn't have any symptoms, but we pick it up on our regular scans that there's an issue, a toll that the treatment took on the brain. Next slide. So the big question is really, the elephant in the room is what is causing this and how can we prevent it? Ramon Cajal, who was one of these big Nobel laureates at the turn of the century, the last century, created a dogma that really nothing in the brain changes. So we are born with the set we have, and from there on it's just degeneration and decline. It doesn't sound so good. Fortunately, he was wrong. And the reason it took so long, because he was a very influential person, and everybody who was teaching in this field would pick up his thoughts and say, whatever it is in the brain, there's nothing we can do about it. So the next slide shows you something very intriguing, which is we learned out of all creatures from the songbirds. The songbirds were to put something on the map that was quite astonishing. A songbird is able to learn a new tune each season. And you may wonder, why is this? Why is a bird able to have so much brain plasticity? Plasticity as a term to take in novel information to an advantage and to make something new out of it, something novel. And investigators picked this up in the 80s. There was one guy, a smart guy, Joe Altman at the MIT in the 60s, who actually claimed, but nobody took him serious at that time, that the brain is not as dead or mute as Cajal claimed, but there's actually some activity. And so his work was largely forgotten until the songbird story came up, and people were intrigued by this issue and tried to look further. Why only in songbirds? How about a rodent, a mammal, a human? Can we understand why that is also the case in humans, or maybe it's just in songbirds? The truth is then Reynolds and Weiss, a Canadian group, did some seminal work on this and put it on the map that they were able to isolate cells from the brain that had features of stem cells. And so you've heard about stem cells a lot. Stem cells everybody has when we are in development, kids, in utero. So in order to even form an organism, you need stem cells. But what's up with these stem cells in adults and grown-ups? And so this was seminal because it was the first time that we knew there are stem cells in the adult brain forming new cells on a daily basis. So it was very revolutionary. And then Erickson and his team back at the Salk Institute in La Jolla in San Diego showed, in collaboration with a Swedish group, that neurogenesis, which is the formation of new brain cells, happens on a daily basis in adult humans. This was quite remarkable. And this was in '98, and so we have come a long way, almost 20 years now, to understand what are factors that triggers this and how can we lead a better life. How can we make these neurons do their job, work for us, create new memories, and enhance plasticity of the brain. So the next slide, I'll give you two examples. This is the first one of why GPS, if it comes not by a smartphone, is a good thing. Taxi drivers in London were systematically investigated and found, research found by imaging and additional studies, that they have larger navigational areas in the brain. And sadly, they would lose this skill if they wouldn't drive taxi anymore. So the essence was that if you use the tools you have without additional devices, you will be able to actually sustain in a key area in the brain that is relevant to memory formation and navigational skills. This is quite astonishing if you think about that we are completely dependent nowadays on GPS systems like the iPhone. And we don't remember these phone numbers from our neighbors anymore. And we don't really know how to get from place A to place B unless we use our iPhone. So my encouragement number one would be tonight, try to do it without the iPhone. Next slide. This is something else. This is my encouragement number two for you tonight. Learn a new skill, a skill that you have never done before. It could be a language, it could be joggling, like in this particular scenario. It could be going to art class, where you say, I'm not interested in art, do something novel. Or learn sailing. We're in the core of a sailing dynasty in Marblehead. So if you do something novel, that will help your brain long way. So I heard tonight between the lines for some of the members here and the participants that they have been very active. And that brings me to the next topic in a moment, the activity part. But this is very important. So here what happens, I just tell you the science behind it. A group of students were put to a test to learn something for 6 months. They've never done this before. And they monitored their brain function, and they saw that something happened quite astonishing, and this led to a paper in Nature, which is sort of the highest impact paper you can get in, that you actually grow new brain areas. So you would say, wait a minute, Cathal told us everything is as it is, and now you learn joggling and you have a new brain area that is activated? How is that even possible? So a tiny bit of a caution, we don't know if this is true brain tissue that has formed, but what's true is that there is a new activity that you never had before. The sad part is if you don't joggle anymore for 6 months, you lose this again. So try to acquire these skills and keep doing it. All right, the next slide. So to cut to the chase, there are 2 areas in the brain that are very, very important and that harbor these stem cells that form new daughter cells. And these daughter cells do the job, including forming the insulation material around your wires, the myelin. And on the next slide, you will see that this is not as simple. There are many other cells that contribute, and it is a challenge to tease out, is it the blue cell that does the job, or is it the yellow one or the green one, and which one has to communicate with each other to get the job done. And so on the next slide, you see that the myelin, which I told you, is so essential and one of the most vulnerable things in the brain that can go wrong. So if you have loss of insulation material, nerve conduction doesn't work well. So thinking gets slower, memory is suffering, it's just not as quick as it used to be. The next slide shows you something that if you take these cells now in culture, you can actually study them quite elegantly. So this is a myelin-forming cell, and you see how they migrate. This is an image taken every 10 minutes, and you follow them in the dish over 1 week. This is a time-lapse image system that now allows you to track each individual cell. And so they have a unique ability, which is they form daughter cells, and these daughter cells do the job by forming myelin. But if this dish gets too dense, they do something that is very relevant for not becoming a tumor. They have contact inhibition. So that means in this room, if we ask another 100 people to come in, it's kind of maybe a little bit dense. And then others would say, I'm going to leave here, go the exit door, because we don't like to have so many people around us. And this is what happens in the dish on the cell level. So they start sensing that maybe things get a little bit too tight. So this little fellow here starts, you know what, I'm not going to migrate around, I'm just becoming now a myelin-forming cell and do my job. And you can track this with a lot of novel ways. So this kind of gives you a flavor of really what happens in the brain, or in vitro we call this. In vitro means in the petri dish. And we track this in the brain as well. So the next slide shows you exactly the same cells. They are labeled in green. And as they mature, go through other lessons and become an adult, they form myelin, and it turns really bright red. And myelin takes up different dyes. So you can, by phenotype, meaning how they look like, by their behavior, and by novel, sophisticated methods track them and tell which cell is what and what they are doing. So you can also do this in vivo, meaning you label cells with different markers and labels, and you can say this is an astrocyte, a neuron, this is a different cell type. And this technology, and this is the only reason I'm showing you this, has revolutionized the field. We are now for the first time able to track things that go wrong in someone who gets treated with chemotherapy or radiation. Next slide. And so, for instance, what you see is that certain areas of the brain lose cell density. So you see this in the control, and you be the judge. There's a difference between the treated one and the untreated one. Much less cells. This whole layer is thinned out, and with electron microscopy on the right, you can even drill down further to the mechanism of what's at stake and what has been lost. Next scan. So this is something that we've done in our group over the past 2-3 years and published last year, which is we looked at what really happens in a patient. So this was a large cohort of patients that had been followed for glioblastoma with chemotherapy and radiation. It was the treatment. And we looked at their brain in much greater detail and identified that the brain actually does lose brain volume. And this was always feared by oncologists, but never really been studied to that depth. And we are now trying to understand what makes this happen and how we can prevent it. The good news about it, not everybody is symptomatic from it. So we have a window of opportunity where one is able to identify problems that occur without having symptoms that are present. And I think that's one of these areas where you actually potentially can stop the process that drives this so-called degeneration where you lose brain volume, even though you're still functioning, and we try to reverse this to some degree. The next slide is something even more intriguing. This is a cohort of patients treated for not even brain cancer. They had cancer to the lung, and we tried to answer the simple question whether chemotherapy given through your veins can affect the brain. And it does. It actually shuts down glucose metabolism in your brain. So glucose is one of these prime modulators of life. You all need it. That's why we had just a steak. We had some other food with it and some bread. And so it helps us to function. But the brain gets deprived from it. So glucose uptake in the brain suffers. And you see this, that high areas of intensity are red and yellow. And after treatment, you really don't see this anymore. And this was quite intriguing for us to recognize and may form an early marker of toxicity so that we can monitor patients better, because some patients do quite well and others don't, and we don't know why that is. So this is sort of summarizing what the current understanding is treatment with chemotherapy as a harsh treatment to the organism something like accelerated aging. We all age. There's no secret about it. And we all have to fight aging or degeneration, as a scientific term for that matter. And the question really is in the room whether treatments that target cancer have such a harsh effect on the human body that aging is actually accelerated, both in terms of memory function or other things. And so the next slide will summarize a little bit what is the good news and the bad news. The good news is that we've actually learned from all of this work that there are certain factors you can do to make things better. And what are these? Exercise is on top of the list, on the right. Enriched environment, go and travel, learn a new language. It's scientifically proven that these are very powerful ways to make the brain work better. Caloric restriction, we should not overeat. It's very important take-home message as well. Antioxidants, we all are obsessed about our vitamins. If you eat them through vegetables and fruit, that's the best way you can do it. Rather than saying, I don't want to just eat my chips and have a vitamin tablet with it. That is not quite as it works. So if you were adhering to a good, balanced diet, this goes a long way. And then there are other things, and we have understood now why antidepressants work, because they work right in the same field. It takes about 6-8 weeks to an antidepressant to kick in, and they work on the same mechanisms as exercise does. And genetic factors certainly play a role, and we are beginning to understand why that is. On the next slide, you see something that is very dear to my work. It's why is exercise and enriched environment so important? If you sum all of what I tell you tonight up in one sentence, it would say go out and do regular exercise. It might be just walking from around the block every night. This goes more than doing crossword puzzles. This goes more than just reading a book. So exercise is the most fundamental drive of regeneration. And that's scientifically shown in many, many examples. And there are some guys who do this at age 89. He was the one who started running a marathon. I don't encourage you to run a marathon now. It comes with other prizes, but what I want to say is that it is a powerful way of prolonging life. Next slide. And so our work at MGH is driven by trying to use that knowledge from basic science to bring it into the clinic and how we can minimize damage occurred by treatment that is necessary to keep someone alive, but we want to minimize the toll it takes and maybe do things that help reboost the system. And these are just some examples that I've talked about and gives you an idea about exercise, diet, sleep issues, genetic factors, and how aging works. So it's a very fascinating field of how everything ties together. I'm not telling you anything new, by the way, tonight. You know about it. I just phrased it in different words. But life and death, in a sense, is very well connected with a lot of dots. And for us to tease these things out is very, very important. And we have made a lot of progress in recent years to now take this to the clinic, to the next level. And this just summarizes a little bit our efforts at MGH, where we have preclinical models that try to assess what is damaging, how it works, and then on the flip side, on the next slide, how we can really advance this to a better management of our patients. So cognitive assessment, novel imaging technologies, you've just heard from Dr. Gerstner in her talk, biomarkers, another key word, what drives disease, what drives recovery, and what drives plasticity in the brain. And then how can we use novel neuroprotective strategies to make this reverse. So pharmaceutical companies are very interested in this because they will give me a target. I want to go after it and make the brain function better. And so these are one of the goals we have right now, because it is so hard to tell someone, go and exercise, and it's much easier to take a tablet. On the next slide, you see there's a big team of people who contribute to this over the years, and we got funding from the Cancer Society and the NIH, but I think grassroots efforts like here from Bill and his group and in memory of Mary are so critical to keep the momentum in moments where the NIH dries out and we just don't have these dollars to keep the research going. So with that, I think we switch to the question and answer session.
Have you done any work with proton analysis, and do you think the side effects are as strong or less if you use proton therapy for brain tumors?
We have, and it's a fantastic question. So for anyone who doesn't know what the protons are, so it's a different way of radiation that uses a different methodology and is considered to be somewhat safer because it targets structures more elegantly rather than kind of going through the entire tissue of interest, in this case the brain, for instance. The truth is that I think if you have the chance for proton radiation, it is likely to be less toxic, but many times you don't have that luxury to do it. In other words, if a structure is too large or too widespread, then proton is not an option. But if you have that situation that some spot that you don't want to have is very small, then proton radiation is a very good opportunity to use. So yes, toxicity is considered to be less in patients who can be treated with proton radiation.
How do chemo and radiation therapy complement one another?
Well, I give you sort of an overview. Obviously, the question requires a very distinctive answer from a scientific point of view, because lots of chemo drugs are acting very differently. But the truth is that radiation, by and large, acts in a different manner than chemotherapy does. So they're complementary to each other. And the complementary part is very helpful for some patients with brain cancer or other cancer, because you just take a much bigger hit on the tumor. The side effect is that if normal tissue was affected as well, then there is a bigger hit to unaffected tissue or organ or brain in this particular scenario. That said, I think from my talk is there is still a lot of hope, which is you can use your endogenous potential to recover. And we all do that. When you have a cut in your skin, or when you have a burn, you do recover from it. And when you had an ulcer, you recover from it. And the same with the brain. There's a way to recover from these damages that are inflicted by treatment. You just have to tease away and enhance this recovery to a more powerful situation than we currently have.
What's different about immunotherapy in the brain? You have to get through the blood-brain barrier. Do lymphocytes do that? And somebody said the brain has its own immune system, the microglia. Would that be a method of immunotherapy, or is that not really relevant too?
It is very, very relevant. This is one of these dogmas that I grew up in medical school. It's like lymphocytes don't go to the brain. It turns out to be wrong. Lymphocytes travel to the brain freely. They go into the brain parenchyma and exit it again. And because of these studies I outlined to you, where you can trace different cell types with markers, that's exactly how it was discovered. So what we found, including my own research team, is that cells from the bone marrow, from your hip, from your knee area, travel through the brain, do something there, and then exit the brain again. These are lymphocytes or monocytes or macrophages. They are cells that are called white blood cells, and they have a phenomenal, fascinating role, and we just don't know what exactly they're doing there. Are there surveillance cells checking out things and then leaving again? And also, one of these knowledges of recent discovery is that the environment where the tumor grows is part of the treatment, because it allows the tumor to grow. If you target the environment, meaning everything around a tumor that is permissive of a tumor even growing, then you have one battle won. And the truth is that decades of research in cancer biology have not focused on the environment. They have only focused on the tumor itself. So, well, we want to understand what the tumor cell does, and then we know everything. Truth is, it doesn't really mean anything, because you need to know what the environment allows the tumor to do. And so this is exactly where these lymphocytes or bone marrow-derived cells come into play, because they orchestrate what happens in the environment.
So, Dr. Gerstner, very cool scans that you're doing. I'm going to have to watch the video later to remember exactly what it was about them, but they're very cool and some innovative information coming out of them. Why are they not the standard of care today? Second question, Dr. Dietrich. I have a dear friend who has the same spirit as my brother, who you've met. Her spirit comes from surviving a brain tumor at the age of about 18 or 20. And she continues to ask the question, why me, why me, why did I survive? And seeing what you've gone through with some of the survival studies, I brought tears to my eyes listening to you, and I'm really interested in how she might go forward in supporting you and your work, not just in fundraising, which she is doing, but maybe in some additional research and how you might talk to her to get her to enroll in some of your post-cancer studies.
So the challenge, so the PET study that we're doing, this tracer is not FDA approved, and so you have to do it in the context of a clinical trial. We're also, the reason it's a pilot study is we're really trying to figure out exactly what this is targeting. It's thought to target microglia in the brain. Somebody mentioned microglia earlier. It's unclear exactly what the microglia are doing in the setting of inflammation in a brain tumor, and so we really need to figure out exactly what that signal means, what that bright spot actually is representing. The MRI that we're incorporating in, looking at blood flow, and we can look at vascular leakiness, those things are starting to work their way into the clinic, but they're challenging to do on a larger scale. It's sort of scaling it up to be reproducible when you're scanned in one of the 7 different scanners that they have at MGH. So that's been a little bit of the challenge. There are different efforts to try to standardize how we do these more advanced MRI techniques to look at blood flow changes. And so that is hopefully coming down the road, actually in the next few months. The National Brain Tumor Society has been working very hard to standardize how we acquire these advanced sequences to look at blood flow. So that is coming, it's close, but it's still hard to fully understand how we interpret the more sophisticated changes that we see on the MRI scans.
So I just give you a twofold answer to your question. I think one is I would be happy to talk to your friend and tell her a little bit about our research work and the most novel, exciting findings, which is how cells from the bone marrow drive repair within the central nervous system and how this can be enhanced. Along those lines, there was just, I think today, a headline which caught my attention on how traumatic brain injury, thinking about NFL, can be potentially minimized through cells from the bone marrow. And the reason is that you have not only the injury of the direct impact on the brain, but also a secondary inflammation that now drives the problem, and that bone marrow-derived cells can actually take care of that fire, of that lingering fire over time. So that goes right into the heart of our work, even though the disease, quote-unquote disease, is a different entity. But I think from what I just summarized a little bit in my talk, I think the take-home bullets for your friend would be that there's good news in a sense that even a brain at age 50, 60, or 70 can recover, but we need to provide the right tools to do that. And the current knowledge allows us to say that exercise, cardiovascular exercise, is the strongest impulse of brain recovery. There are many other factors, but so that would be one of my messages to her.
What sort of specific things, good things, have happened over the last 4 years that we should be aware of since you first talked to us that you'd say, yeah, that was a real step forward for us?
I think, by incorporating a lot of these correlative studies, and by correlative studies I mean the imaging studies, some of the blood biomarker studies that we've done, we've gained a lot of knowledge on why drugs don't work, which is maybe a little bit unsatisfying because we haven't found the drug that works, but we figured out why drugs are not working, and hopefully that will inform drug development going forward and how we can combine different therapies together. So drugs targeting tumor blood vessels was a very hot topic, but we have a better understanding now as to why those drugs have not lived up to their potential and how maybe we should combine them with other types of therapies. How we should maybe combine immunotherapies with blood vessel targeting drugs. These things have informed how we design our next set of clinical trials. So it's maybe not we found the silver bullet, but we sort of found ways of making the next incremental step forward.
And let me reach out a little bit further, because there have been, outside of our personal field, Dr. Gerson's and my field of neuro-oncology, there have been a lot of progress been made in neurosurgery, in radiation oncology, and even in pathology. And so neurosurgery, for instance, I'm not an expert, but I can speak for my colleagues that sophisticated technologies, intraoperative management with sophisticated imaging have allowed to do much more advanced surgery than I think the field was able to do 20 years ago. Same applies to radiation. Now having maybe methods in place that spare certain areas of the brain that are very vulnerable and they should not potentially be treated. Let's just shield them in a more sophisticated manner. And then lastly, I think personally what I feel is the biggest breakthrough over the past 4 years is the understanding of what markers exist in any given patient to predict us how this patient will fare. And this is so important because we now know if a certain marker exists, let's just not get too crazy with the treatment. This patient will live a long time, and let's be very easy with what modalities one should choose. Or to say this is one of the most challenging situations we've ever encountered based on a set of markers we need right now to offer everything we have. I think this is what I take away from the past 4 years of a more precise patient management rather than saying, well, I don't know what to do, you just one law-fits-all approach.
There was a lot of news about how leaders of clinical trials were not, they were ending their trials maybe before the end of the trial, but not reporting why or even completing the trial. They didn't send in reports, an analysis of their findings. And since all that came out, are some of the hospitals, the universities, and centers now forced into presenting their findings so that that information is available to oncologists and doctors all over the world?
I think this is a problem within the system of academia that incentivizes individual success. And the problem is that a lot of trials are run by few investigators, and if the story is not good enough, they drop the ball. If the story is not good enough, we can't publish it in Nature, for instance, which I just showed you. It's not good enough, let's not talk about it. It's actually one of the problems I had at the beginning of my career, that I came out with news that nobody wanted to hear about. I was rejected by the American Academy of Cancer Research and ASCO by saying, we don't want to hear about this news. You don't fit in our image. This was about 15 years ago, and it took us a long way to finally get some groundwork to say there is a problem. We need to talk about quality of life and survivorship, and not just about cure. And so this is exactly what you're talking about, is we are driven by success stories, and if something doesn't go right, we'd rather not talk about it. And so I think in my eyes there should be much more incentivized ways of talking about failed tries in a similar way than about successful trials. Maybe you have another sense to that.
So now every clinical trial needs to be reported on clinicaltrials.gov. So you can go there and find every trial that's registered in the United States, and a lot of international trials are registered there. You now have to report your results on clinicaltrials.gov, or else you can get up to a $10,000 fine. So having just received one of these emails saying that my trial was not up to date on reporting on clinicaltrials.gov, I am now very familiar with these rules that have been passed. And it is a new rule that has been passed because of this argument that these are often taxpayer-funded, NIH-funded clinical trials, and so they should be reported and open to everybody. So you will see a shift that these results will have to be published on clinicaltrials.gov, or else the investigator, or more importantly, the institution, because this came from my institution, saying you need to report these results or else we are going to get in trouble. So there is a stick now so that people will have to report their results. It's not going to be in necessarily journals, but it will be online for the research community and patients to look at. And it has to be reported within a certain time frame of the trial being completed. So a lot of the trials that do get shut down because of futility or lack of accrual, that results will be available for people to look at.
The use of some of these tools and the potential failures, I mean, there are obviously steps in the progress of every kind of therapy. Last year, I recall you talking about polio as a tool or whatever, as part of the process. And this year, it's not mentioned. Am I to assume that that was one of the steps that just didn't work and so you move on?
I think the story on the polio vaccine is still an open question. So that was a small single institution, early phase study, and those results need to be replicated in a larger study. That's not going to happen, unfortunately, in a year's time frame. That'll still require another 2 to 3 years before we have final results from a larger study using that particular tool. And so this is the other challenge that we face, is that you try these tools, but you still have to wait several years to see if they're actually effective or not. So 3 years from now, I'll close the door on the polio vaccine.